My name's Ben. I'm a third year medical student at the University of Sheffield, and my project is looking into some of the social and political determinants that affect the health of travelling communities. Um, so when we talk about travelling communities, the official designation is Gypsy, Roma and Traveller category. And this category is a bit of a sort of a catch-all term because it encompasses lots of different groups of various different ethnicities, different languages, and different histories. And the official figure has it around sort of 70,000 people self-identifying as Gypsy Irish traveller as per the latest census, but estimates put this number at a much higher figure of about 300,000. And the disparity between these two numbers is in part attributed to a reluctance to self-identify, which I think is the real crux of the issue. This phrase here on the slides is something that I've seen in various different articles and even academic papers. I think it was first coined by the Commission for Racial Equality, and I think it highlights the social acceptance of prejudice and discrimination against people in this category, because although they do have different cultures and different ethnicities, there is almost a shared prejudice against them in society, and unfortunately this does reflect on health outcomes for these communities. So if you look at some of the metrics, and this is just a snapshot, the life expectancy is significantly lower than that of the general population. Suicide rates is a lot higher, as is prevalence of anxiety and depression. And in terms of primary care, people from these communities are much less likely to be satisfied with access to a GP. I think the true scale of these inequalities is often hidden because, I mean, these are just sort of figures you can find online, but the health surveillance of these communities in general is quite poor, to be honest. A lot of the evidence I found is either sort of anecdotal or quite dated. So I would say take these with a bit of a pinch of salt. So my project was a reflective project. It was a mixture of a bit of a literature review, which I then used to identify themes and take forward into in-person meetings with healthcare workers who were involved in the care of these communities in the 1980s, like the heyday of radical practice in Yorkshire. And from this, I derived a few case studies, which I used to maybe identify some solutions that could be used to tackle these determinants of health and these inequalities in the modern day. And in order to sort of find a framework for this project, I mean, initially I thought about the medical pillar of justice, which a lot of medical students are familiar with, even pre-applicant students as well. But then my supervisor mentioned something that I suppose sparked a vague recollection of a lecture I had in first year. And this was the inverse care law, which briefly states that those with the greatest need of healthcare services often have the least access to them. And it was coined by this GP here, Julian Tudor Hart, who was working in sort of socially deprived areas in Wales. And initially, I think it was established to maybe act as a warning against the impact of market forces in healthcare in the UK. But I think a really apt application of this law is when you look at Gypsy, Roma and Traveller communities who often have very unique health problems and unfortunately barriers to accessing healthcare, such as prejudice, discrimination and poor health literacy, as well as others. So in terms of accessibility, this was one of the first themes that I identified. So I've got a list here of some of the factors that may pose as a barrier to accessibility. And this is by no means an exhaustive list, and I'm not going to go through each of them, but I just want to draw your attention to this idea of cultural competence as a factor, an external factor. And cultural competence is essentially just possessing the cognitive, behavioral, and the linguistic abilities to work with people from different cultures. And a lack of cultural competence, I suppose, logically presents itself as a barrier to accessibility, even maybe making way for prejudice, discrimination, and perhaps outright hostility. Additionally, as well, flexibility or inflexibility is a barrier for these communities when accessing primary care support. And one of the meetings I had was with a group of healthcare workers in Sheffield who were inspired to reach out to these communities And just to give some context, so in the 1980s in Sheffield, the health inequalities between the sort of GRT communities and the general population were even more pronounced than they are today. There was a report that was released that showed that perinatal deaths were as high as 50%, which was comparable to sort of contemporary Guatemala. And these healthcare workers were then inspired to tackle some of these barriers to accessibility. So they repurposed an old television van. You can see it in the photo there, that blue van. And they would travel to these sort of traveler sites, sort of build rapport and trust with them, and again tackle some of the that barrier of accessibility. And this was fully equipped. It was literally a GP clinic on wheels. It had a reception room and examination room. And gradually, some of the metrics, some of the perinatal deaths and immunization rates began to improve over the coming year. And then focusing again on maternity. So I found a systematic review of various papers produced in sort of different European countries, and identified some of the problems that sort of mothers from a traveller background would have with maternity and sort of early childcare. Just a few of them being that they would be generally younger when they were giving birth. There's a higher incidence of unwanted pregnancy and an increased risk of low birth weight. But in Sheffield, a GP that I spoke to described the maternity scene as a bit of a sausage factory with like a one-size-fits-all template and a default of hospital births. And we've touched on a bit about how this might not be necessarily appropriate for women from a traveller background, partly due to the very real fear of prejudice and discrimination that could act as a major disincentive to get the proper care and support that they needed. So one solution was the establishment of a flexible maternity clinic in Northern General Hospital that operated in sort of like a drop-in model and had hours that suited the needs of traveller communities. But additionally, a sentiment was beginning to form that was more centred around the patient and the mother, and it sort of championed their autonomy and their wishes for home births, which in many cases was more suitable for traveller women. And again, the healthcare metrics, perinatal deaths and neonatal ICU admissions also dropped sort of following in the following year. And now if we're looking at some of the more, I suppose, social factors. So I met with members of the Sheffield Gypsy and Traveller Support Group, which was as a coalition of social community and healthcare workers that were sort of focused on outreach to local traveller communities across three major domains, being welfare rights, adult literacy, and mothers and under fives. And they established a formal premises in Attercliffe in 1981. You can see that in the photo there, sort of what it looks like today. And this was very accommodating for sort of traveller groups. It had a childcare facility, sort of a nursery to accommodate larger families, as well as a parking area for trailers and other vehicles. So it was a very sort of friendly, non-judgmental and welcoming environment. And additionally, they utilised sort of local play buses and play initiatives for sort of, children from a Roma background that wouldn't necessarily have the chance to engage in play. And gradually, over time, this built up more trust with the community. And it's I think it's a bit of a almost universal law that, you know, if you as a patient trust your doctor, you're more likely to disclose things that could lead to a more accurate diagnosis and therefore better treatment and overall a better outcome. But a key outreach strategy that they used was involving members of the community in order to sort of build those bridges. I'm focusing more, I suppose, on the political side of things. So these are two campaigns that I investigated from sort of different time periods, and starting with the Labour campaign for travellers' rights. So this was set up in 1986 as a pressure group within the Labour Party. And the purpose of this group was to change Labour Party policy to become more favourable to travellers, for example, by establishing some more authorised traveller sites. And they managed to gain a lot of support from prominent politicians as well as national unions. And it logically follows that more established traveller sites, better equipped facilities, have loads of benefits on health outcomes ranging from prevention of disease as well as physical proximity to healthcare services. But more recently as well was the EU settlement scheme, which was established in the wake of Brexit. So after freedom of movement was, I suppose, lost because of the UK's exit from the EU, EU nationals living in the UK had to apply for assessment status, which ordinarily was a very arduous process, but for some Roma Slovak communities, it was complicated further by language barriers or poor access to equipment needed to make an application. We talked about digital exclusion before. Maybe even lack of understanding about the scheme in the first place. So Donald Wellbeing, who had already built links with these communities and established trust, were able to use that to reach out to members of the Slovak Roma community who are eligible for the scheme and help them with their applications. And again, the people involved in this project had a high level of cultural competence. They understood the language and the cultures of the communities they were interacting with. So this project was incredibly successful. And by the end of the project in 2024, about 8,200 people were supported with their applications, and 1,700 people made their applications through DWB directly. So I suppose, as I say, this is a reflective project, and there were some key learning points that I took away from my time with Sheffield Community Primary Care. I think the first being, I read somewhere that Tudor Hart was almost regretted coining the inverse care law because it became somewhat of an academic term, sort of thrown around without any sort of practical substance behind it. And I hope I've demonstrated that this situation is a perfect example of it. But also I hope I've I suppose conveyed some of the practical solutions that were implemented previously that I think perhaps could be implemented again to reduce health inequalities and improve health outcomes for these communities. And the term GRT, Gypsy Roma and Traveller itself, is it was an incredibly broad term. It's encompasses Roma Gypsies, Irish travellers, Scottish travellers, Welsh travellers. And I think the criticisms, I suppose, leveled against that term are similar to the ones leveled against like the BAME acronym, in that it's it's not very sort of tailored. It's almost sort of too broad and too generic. And I think it's almost not very useful for cultural competence. And the second learning point, I think, as well, when I was looking at the mobile clinic in the Attercliffe support group, these were funded by sort of local authorities who theoretically knew the problems of these communities and were able to give money towards tailored solutions. And I think in many ways, centralization of healthcare as well as other services has almost made these tailored solutions less of less of an option. So that may undermine sort of future initiatives. And finally, as a medical student, I think the cultural competence aspect that I was talking about, I think it does begin in the early stages of healthcare training. In Sheffield, we use a patients as educators model where we get patient volunteers with a long-term condition to come in and speak to medical students, either in a seminar room or in a lecture theatre. And I think something like this for patients from either like a Roma background or an Irish traveller background could be very useful to medical students in the early stages of the career, and give them something to, I suppose, take forward into their later practice. So I think ingraining it sort of early on is quite important. And yes, these were the references I used for this presentation. And I'd just like to thank these people for giving up their time to speak with me and contribute to the project.
Well, fantastic. So I'm opening it up now to questions or observations. We try and be quite strict with not going over 59.5 minutes. So we've got about 10 or 15 minutes if you need. And Ben, are you happy to answer questions?
Yeah, absolutely. Yeah.
Excellent. So any questions or observations, Martin?
Could I congratulate you both on your presentations, which were very, very helpful. It would be lovely to have copies of those if that were possible. May I ask what you are considering taking forward? I know these were projects that had a deadline of today, but I'd be interested to know what your feelings are about, both of you, how you wish to take your observations forward.
If I'm honest, for me, I think some of the research, like I said, is quite sort of outdated, and some of the health surveillance is again quite poor. So I think, I mean, I'm interested in primary care already, but I think that definitely needs improving, or sort of a more up to date and sort of cohesive way of monitoring the health of these communities. That's sort of tailored to the individual sort of backgrounds of the communities. So I think if I could play a role in that, I mean, that would be pretty good. But yeah.
I think for me, um, kind of some of the issues that I'd spoken about were ones that I personally wasn't as aware of, I think. And I think one of the easiest things to do is to make kind of peers and those around me also aware of such issues so that they acknowledge that they are there when they go forward in their practice, and however each person might choose to, I guess, combat that. But just the concept of the acknowledgement of that being there. So, because without, I think, these 4 weeks of placement where I was really concentrating on these topics, I wouldn't have been that aware of kind of the effects.
Any other observations, feedback? Paul.
Again, thanks for your presentation, Ben. Fantastic. I don't know. You just seem so competent at doing these presentations. I don't know whether you've had lots of training in it. I don't know. I spent a lifetime trying to get that confident. So well done. I was interested in you use the term quite a lot about quite often cultural competence. And I think I know what you mean, but I just wondered what your training, have you had training on this? Have you had, because I think that there's some people who almost sort of intuitively, or maybe because of their families or the schools or whatever, are highly sensitive and on top of this issue. Whereas when I was a student, I was afraid that in fact, most of the students were miles away and had tended to come from very privileged backgrounds and didn't really know what the hell was going on in most people's lives. Just wonder if you'd like to comment.
Yeah, no.
About what the current situation with medical students is.
Well, for me, I first came across the term cultural competence because through one of Patrice's papers, and it was a very good sort of comprehensive paper, but it's not a strict term that I'd heard before. And I completely agree. I think in terms of education at medical school, I think there's a lot of good progress that's been made and a lot of good initiatives at improving cultural competence. They don't even say the word directly, but they talk about specific healthcare needs of various groups. But I definitely agree on that. I mean, I came from I suppose a quite a privileged background, really. So I think I think definitely some more sort of formal education in medical school might be sort of warranted. I think certainly, I mean, I'm not sure about yourself, Hannah, but I don't remember learning too much about the various healthcare needs of people from these communities. But I think that's why something like patients educators might be very good, sort of useful.
Yeah, thanks. It's interesting. Yeah, thank you.
Hannah, do you want to add anything?
I agree with Dan in that we're taught it to a degree in medical school through kind of various lectures, but I think the idea that Ben put across in his presentation about the concept of patients as educators and the patients that do come in, it is volunteer led, but perhaps seeing a bit more of a variation in the patients that we do see. So the communities like Gypsy Roma travelers, that would, I think, very much help going forward. I think that was a great kind of idea.
Could I just come back, Tom?
Of course.
I'm remembering listening to you talk. Goodness. There were three of us on this call went to the same medical school. And I just remember there was just enormous variation, but there were some doctors who almost universally come from privileged backgrounds, but who absolutely had got it. and really would listen to patients in a really good way. And I suppose, I hope that they were our role models, but it was far from universal, it has to be said. And I guess it probably still is. Anyway, just a thought.
Okay, Jack.
I think during one of our meetings, somebody said you can't work with gypsy travellers. I'm going to use that term because that's what I did in my time, without being political. In other words, understanding, obviously the cultural connections, but also the wider, let's call it politics, national, international, the Roma moving around the world, and the sort of issues of discrimination and racism and all those things that we did talk about. Unless people have some understanding of those issues, I think it's really hard to focus on the needs of communities in the way that Paul was talking. So I think that's, hopefully you've got some understanding of that. And so Paul and Maya and I were at Bristol Medical School in the 70s, and here we are, three of us somehow are in this meeting and came to Sheffield. And so there's something about our time as medical students becoming, more aware politically and taking that forward in our lives. And I suppose I would hope that you both can do some of that as well.
Okay. Oh, we've been joined by Gwen. Hello, Gwen. You're muted at the moment. Hi, Gwen. Shall we move on if you can't find the button? Oh, there you go. Did you catch how much of Ben's presentation did you get?
No, I didn't. I'm sorry,
Oh,
I
bad
didn't.
luck.
No, I was out. Yeah.
No worries. But welcome anyhow.
Thank you.
So, any observations we can do with stories, Ian, Penny, Martin, about the gypsy community that you had the advantage of working alongside those communities very much. Penny's nearly unmuted. Well done.
I am unmuted. No, I was just going to say, I mean, just sort of picking up on Ben's idea of, patients as not advocates. I can't remember what the phrase was, but anyway, trying to actually bring something into the training. One of the things that we did quite regularly when we were involved was in relation to training of police officers. And because obviously, I shouldn't say obviously, there was a lot of racism, inevitably, actually. And we were actually invited in over a number of years to actually go in with travellers into the training and actually try and shed some light and, gain some more understanding as to what some of the issues were that were going on in the background for people. Hopefully it helped, but obviously you have to be an incredibly confident person to go and put yourself in that position to actually speak to people who are not necessarily positive towards you. So I think it's a great idea, but it will be quite hard to actually set up. You'd need a lot of support around that process if you were going to try and do it.
Yeah, no, I definitely agree. I see some of the complications. I mean, the scheme's already established in Sheffield. I think it's been going on for a few years, but no, I definitely acknowledge like the difficulties that might have sort of setting it up.
Ian, did you have your finger raised at one stage?
I did. I think the sort of the whole concept of patients being educators, certainly for me, I learnt so much from working with the community in so many different ways. It was utterly extraordinary. I think that one of the first things, because back in the day in the 80s, sort of, far too many of us became smokers and so on. And I remember one gypsy man, we went to visit this particular encampment, and his name was Dai Li, and he introduced himself, and he had a pair of twins who was extraordinary, lovely guy, and he just said, oh, I'm a pastor, Christian pastor, and he said, I noticed you smoking, and he said, that's really quite bad, because your body is is the temple of God, and you shouldn't be doing such. You're abusing the temple of God. Stop doing it. And it really stuck with me. I thought, wow. And I'm not a religious person. I don't have that sort of approach to life at all. But what he said to me at that time is stuck with me to this day. That that attitude. But it was in so many different ways that I learned from the community. That it's taken me forward not only in a professional life but in personal life as well. And one of the things that was the whole thing about just working with gypsies and travelers was highly political. I for one job that when I moved to Bristol, I was working for the county council in the equalities unit. I was interviewed by the whole subcommittee of resources committee, which was like the sort of the cabinet of the authority. And there were 30 people, 20, 30 people interviewing me. It was extraordinary, just for sort of an outreach work, equalities work with the community, highly political. And just being a gypsy and a traveller, I think to this day is just a highly political issue, for so many people, that affects their lives and affects their health. Absolutely, absolutely, absolutely.
Martin, and this will be the final contribution. Thanks.
Can I just quickly say that I wish I had lived and worked in Sheffield, because in the rest of the UK, there is an awful lot to learn from what we have heard this afternoon. And I would hope that the presentations that we've received could be shared widely within the medical training profession, so that perhaps Ben's idea of using patients as examples for training could actually be much more widely used than just in Sheffield.
Thank you. And Martin, I do have to say that I think we've been telling you to come to Sheffield for at least 35 years.
I know.
So it's on you. So just winding up now. So we've had some. Sorry, Fran, was that your hat?
Yes, sorry. I was just going to say, in case it just, I know a couple of people have said it'd be useful to see the presentation. I will put them on the Community Contact Tracers website afterwards. So recording of the presentations and then the slides as well, if Hannah and Ben send them to me, so I can share a link with the people that have been on this call and just more generally, I guess, as well, if anyone wants to see them. It will take a little while for me to do that, I'll be honest.
No, sure. So, Fran, thank you for setting all this up and all the fantastic work you do behind the scenes. It's just magnificent, really. And thank you, Martin, Penny, Ian, Gwen, Maya, and Steve for coming on this call. And special massive thanks to Ben and Hannah. You held it together beautifully. And as Paul said, it's wonderful to see such skill and sort of all the information that you've got to converted into a short amount of time, but very succinct and beautifully presented. So well done.